Mr. Chairman, colleagues, President from the VSI company, thank you for inviting me and be so nice and treating me so well. So I really enjoy to be here in Istanbul today. It's nice weather, so that's also a good thing. So we are going to talk about the sinusoidal trifocal IOL, the Trinova. And we have some initial preliminary outcomes, and this I want to share with you. Yeah, okay. These are my credentials, financial disclosures, and I'm past president of the Belgian Ophthalmological Professional Society and the current president of the Belgian Society of Cataract and Refractive Surgery. My multifocal experience begins fairly early, and thanks to Professor, I have learned that in '93, when I graduated ophthalmology, I think we were the last ones to have seen intracap, extracap, phaco, femto, and so on. So the new generation doesn't know how to do an extracap, doesn't know how to do a very mature cataract. So we had the privilege of having all those surgeries. I started out with intracap in my residency. I did 80 extra caps in my first 3 months of my professional beginning, and then immediately switched to 94 to the phaco. So that resembles me that we are getting old. So all the trifocals are not the same. We are talking about the sinusoidal, and I want to talk about the influences in the clinical choice of a multifocal IOL. So what influences me in my clinical choice? There are some obvious ones, like the retinal and chromatic aberration control, square edge. The light transmission is very important. The glare and the halo side effects, they need to be minimal. A good centration on the visual axis during surgery, and very, very important, no decentration postoperatively. The mesopic conditions should be acceptable for far and near. And I added a last one, and that's thanks to the VSI company, continuous vision, because you were the first to really offer what you promised. Thank you for that. So the study design has 2 arms. The first study arm is a sequential prospective study, and we measure the refraction, visual acuity, visual performances far, intermediate, and near. And the second study arm is the question of the quality of life questionnaire, and we use the VF14 file translated in Dutch. So the first study arm, there are 60 bilateral spherical multifocal Trinova patients. They were hyperopic, they were bilateral, uneventful, no concurrent eye disorder, male and female, the same flex femtolaser assisted cataract technique, and the same surgeon. So this study has been initiated since the beginning of the presentation of the Trinova, and is currently running and will be presented at the ESCRS in Paris in September. So the preoperative evaluation is very important, because we are now in the transition that a cataract surgeon is becoming a refractive surgeon. So if you would like to implant multifocal IOLs, then you need to be sure that you can deliver what you promise. And the LensStar optical biometer, with the laser measurement of all the parameters in the eye, and of course the lens thickness is something we now have known as very important. the anterior K readings and the advanced modern formulas which are on the LensStar make us a very good friend with ophthalmology and refractive surgery. So we evaluate the cornea also with the pentacam, and we look at the true corneal K readings. We use the Virion astigmatic planner, and of course we did an OCT to see if the macula is immaculate. So the femto laser-assisted robot surgery, why did we do that type of surgery in this study? Because we wanted to eliminate every irregularity in our technique. And the Lensix is very good in precise capsulorhexis, a consistent capsulorhexis. It's always the same size. And we can call it a standardized surgery. The same incisions. It's also with the femtolaser that we make the incisions. And we use the Virion astigmatic planner for the centration check, which I will show in a moment. This is my OR in the extramural setting. So the femtolaser assisted cataract surgery and the Virion digital marker make it possible to have an excellent centration check at the end of the surgery. And you can see me cleaning the backside of the IOL, because it's very important to eliminate all the viscoelastic behind the IOL. So at the end of surgery, you can have a very good centration, and I mark that in my electronic medical device of the patient, so that I really have a good feeling while ending my surgery. So the first study arm, what we saw is, in our preliminary results, is that there is a high predictability. We didn't do any LASIK touch-ups, which we had to do with other multifocal IOLs. But in this study, we could see immediately that the predictability between the LensStar biometer and the multifocal IOL, which is produced with a very precise diopter, that we can produce a very good outcome. We use the Barrett universal formula, the Olsen formula, which is one of my favorites, and we use a theoretical formula not to have the diopters of the implant, but to see if the eye is normal. Because in the Hill RBF, you have a question mark. If an anatomical parameter is incorrect, then your eye measurement is out of bounds, and it's noted on your screen of the LensStar, and that's very important because you cannot promise to an eye, to a patient who has an eye out of bounds, that in one surgery he will be gaining his uncorrected visual acuity maximum. So this is fairly important to promise to your patient what you can be able to deliver. Continuous vision is something which is new and introduced by VSI, and nothing better than simply showing a video. If it's working. There it is. Could we start the video? Because, yeah. So I instruct the patient to look at the Snellen tree line and having a go until he doesn't see anymore and he is continuously reading what's presented on the paper. And do you know what he said when he stopped? He said, "My arms are not long enough." So you really have a good continuous vision with this Trinova lens. Uncorrected visual acuity. I like to remember that it's astigmatism less than 0.75, so we didn't include any astigmatic surgery. And these are the cumulative, uncorrected visual acuity and Snellen line from 30 patients. It's preliminary. And we can see that there is a very good vision of 12/10 and 3.3%, an uncorrected visual acuity cumulative of 89.4, 98.4 10/10, and 100% above 7/10. Why is it lower in 10/10? Because we had one eye with the cystoid macular edema, which is currently under treatment, and we haven't yet measured that patient again. So it's very good uncorrected visual acuity. What about the near vision? What we see is that we have 10% in the preliminary results of 30 bilateral patients, 10% 1.4 Snellen. The majority, and more than the majority, 60% and above, is Snellen 2, and the rest is at least Snellen 3. We didn't do any YAG capsulotomy either, so it could be that this is influenced also by capsule not clean enough. We will have that in the results in September. So the uncorrected near, you can go to, the mean is Snellen 2. The near distance is between 38 and 42 centimeters, and the intermediate vision from 42 centimeters to 82 centimeters. What about the second study arm, the quality of life questionnaire? We ask specifically for the presence of visual disturbances, visual lifestyle activities, spectacle independence, and the satisfaction. We eliminated one question in the satisfaction of the VF14 file because it was stated, would you recommend the same lens again? They don't know a difference with another lens, so how can you compare? So we eliminated that question. So you will be anxious to hear about the halo and visual disturbances. And then you have to read the recent report of the GSCRS in 2018. It was written by Thomas Konen. And these are where you can find it, but you all have the Journal of Cataract and Refractive Surgery, I think. And these are patient-reported optical phenomena between two recent trifocal IOLs. The trifocal IOL on top is the one from the company with a Z, and the panfocal is one from a company with an A Alcon, the Panoptics. And what you can see is halos in the first trifocal, 65% and 90% in the Panoptics. And it was written by Thomas Konen, which is a consultant like me for Alcon. So it's pretty clear that they have a halo problem. What is important and which is not fairly visible is the double vision. Double vision was 15% in the trifocal and 10% in the Panoptics. And double vision is sometimes what we hear in those other types of trifocals, and we have never heard that in our series of Trinova patients. So what do we have? We have less than 15% halo mentioning by the patient, and the distorted vision is non-present. One with double vision, but this is the cystoid macular edema eye, so we cannot really count on that. That will go away, I think. Ghosting is also non-present. The blue one is the Trinova. So compared to the other, compared to the other trifocals, it's a very good, excellent quality of vision, minimal halos, and a very good mesopic visual acuity, which is fairly important for driving and also for other means at night. So in conclusion, we can say that with the Trinova preliminary results, we have an excellent far vision, also in low mesopic light that has to be accounted for by the high light transmission of 92%, as we had heard before. The continuous vision is near from 38 centimeters to 80. It's continuous, minimal complaints of halo, spectacle independence is very high, and it gives great satisfaction even in mesopic conditions for our patients. And therefore, the staff and the doctor is also very happy, which brings in new patients, and this is fairly important for a refractive practice. I thank you for your attention and very kind for your invitation.